Hello, my name is Ravi Vij. I'm from MyCancerHaven, and we're delighted to welcome you to our inaugural Expert Roundtable series, Guidelines in Action, Empowering Community Practice Clinicians in the Care of Patients with Multiple Myeloma. In today's program, we will discuss managing heavily treated patients, those who have received more than 3 prior lines of therapy. MyCancerHaven is a 501(c) organization with a mission to support and empower patients, caregivers, healthcare professionals, and healthcare organizations using dedicated, innovative solutions tailored to the unique care of cancer patients. The goal of this expert roundtable series is to focus on practical applications of the available evidence for the care of patients with multiple myeloma. To do this, we have brought together a fabulous panel of experts whom I'd like to welcome today and thank you for being here. I'd like to welcome Dr. Ola Abdallah from the University of Kansas Medical Center. Welcome, Abdallah.
Thank you very much for having me here.
Dr. Jesus Berdeja from Sarah Cannon Institute in Nashville. Welcome, Jesus.
Happy to be here.
Dr. Caitlin Costello from the Moores Cancer Center at the University of California, San Diego. Welcome, Caitlin.
Thank you. Delighted to be here with you all.
Dr. Cristina Gasparetto from Duke University School of Medicine. Welcome, Cristina.
Thank you. Happy to be here too.
And Dr. Gurbaksh Kaur, who's recently moved to Mount Sinai in New York. Welcome, Gurbaksh.
Thank you for having me.
This program is made possible by a generous, unrestricted grant support from Sanofi and Janssen Pharmaceuticals, and program support and development has been supported by Cancer Communicator. Today, our focus will be on heavily pre-treated patients. Our program will be in 3 parts: new data with implications on current care, practical aspects of current care, and future directions. So patients who are heavily pretreated have poor outcomes. With today's combination treatment strategies, patients who have received 3 lines of therapy have generally been exposed to immunomodulatory agents, proteasome inhibitors, and anti-CD38 antibodies. Historically, these patients have had poor outcomes. However, we have seen a shift in the last couple of years with the availability of T-cell directing therapies. The first CAR T therapies were approved in this space, cilta-cel and ide-cel, and then came the bispecific antibodies. And we now have 3 bispecific antibodies that have received accelerated approval based on phase 3 data. 2 of these are BCMA targeting, teclistamab, first approved about 2 years ago, and elranatamab approved in August of 2023, and talquetamab was also approved last year. And now we have more follow-up and additional data sets on these patient subsets. So I'm going to ask my esteemed colleagues to weigh in on some of the latest data that we have. One of the data sets that we are now starting to see emerge is, in addition to the clinical trial data on CAR T, we're seeing real-world analysis of CAR T data emerge. So I'm going to call on you, Jesus, first and say, Jesus, so at IMS, we had, I think, more than one presentation on real-world data, including on cilta-cel, and it appears that we are starting to recapitulate some of the clinical trial data. So what is your own read on the data that has been presented on the real-world analysis of CAR T in later lines?
Yeah, no, I think that's an excellent question. I think, the clinical trials are always so modified, right? There's the population included is so specific, so it's hard to really make it applicable to the real world. So I think that's where the real world data really comes in to help us understand those patients who are excluded from trials and what their outcomes may be. And so that's what I take the most from the real world data. Remember that in the real world, though, it's less controlled, so it's also difficult to really take it on faith, specifically in the outcomes section. I find it more interesting from the toxicity standpoint and applicability. There were a lot of eyebrows raised with the presentation at IMS comparing ide-cel and cilta-cel, which we all discussed, but obviously, again, this is not a true head-to-head comparison. This is just outcomes of individual patients treated with the drugs. So I'll leave it at that. I'm curious to see what others think.
Yeah, I think that obviously cross-trial comparisons and real-world data comparisons between drugs may be a little fraught with difficulty. But as far as the actual data goes, there was also a presentation, I think, by Dr. Subi Sirdana on cilta-cel real-world experience.
Uh,
So is there any highlights from that that you think are worth mentioning?
I think like Jesus would say, the clinical trials are very well controlled, and in the academia setting, we're trying to select the patients, right, for clinical trials. So I love all the data from the real world that they're coming out. I've seen a few from the IMS, how to manage toxicity, and myself too, I'm learning how to use these drugs. And for instance, patients that will never have been eligible for clinical trial, like patient on dialysis, right? And that was, I just treated one last week, and I was pleasantly surprised. So I think we need to have this real world data coming out, so we can learn from our experience how to best, deliver these drugs, and managing toxicity, and helping the community physicians, educating them, not only on the data that they're published, but also on our experience. So I love that. So, but there were many presentations, a lot of presentation about managing toxicity, long-term, the responses, and they were quite intriguing, actually.
Gurbaksh, anything that caught your attention in terms of the data? It seems like some of the real world data is recapitulating the clinical trial data, perhaps even in a population that is not fit for clinical trials, it seemed like.
Yes. So I think overall, what we need to keep in mind is the data that has been published from the real world when it comes to ide-cel and both cilta-cel was mostly, early on when these agents were approved and patients were heavily relapse refractory, so their disease couldn't wait. So early on, we may not have seen the same outcomes that we were observing in clinical trials. But the abstract or the paper that Surbi Sidana eventually published in Blood, right, on the cilta-cel real world experience, I thought was quite impressive, because as you said, about 56% patients did not meet the criteria for the clinical trial, but these patients were still able to get CAR T. And overall response rates were pretty high, upwards close to 89%. There was a mention, I think long term, we would have to see we know the short-term toxicities, right, which are infections or cytopenias and everything, but what are the long-term toxicities, the secondary blood cancer, secondary cancers, that will sort of come out with time. But I think that, to me, that was one of the most impressive papers or data that came out of IMS in the recent months.
Abdullah, did you happen to have anything that caught your eye?
Well, I mean, I think I echo all my colleagues about talking about the real world data, but what really actually matters, in my opinion, is that there's still some subset of patients I would like to see, the real efficacy and the toxicity for these patients. Like, for example, as we mentioned, in patients with renal failure and hemodialysis, we have very few information about it. I think the real world data in the future will show us maybe how much is it effective. I know, we have case series in bispecific that we have show good results. We don't know the impact of CAR T cell, like in terms of, I know that age has been a question mark about it, and frailty. In our center, we really have a very strict way to choose the patients for CAR T cell. Not everybody, whether they're, and later and heavily treated after 4 lines or newly or after 1 line of therapy, there's a very strict way to choose these patients. So, I mean, most of our patients population, I don't know if other centers do the same, is like kind of close to the clinical trials. They try to kind of do that. Some of them maybe a little bit like out of the clinical trials. The commonest patients who are not like candidate for clinical trials are those who got exposed to BCMA, for example. I think the thing here is that I would like to see those patients who have comorbidities like heart failure, or, patients who have a little bit poor performance status. Is this CAR T better for these patients or not? I know it's very difficult in real world, but I think maybe in the future we will see these results.
Caitlin, you have the last word.
Gosh, how can I say it better than everybody else? I mean, I think practically what I'm most excited about hearing is, the cherry picking that happens for clinical trials is real, right? And that is not what our lives are like. And access is enough of a problem for CAR T. While admittedly is getting better, why limit it to all these patients when we know that the real patient out there has heart failure, as we just heard, or has, on dialysis? So I'm interested in the access that I know Surbi really nicely kind of outlined, and who is getting CAR Ts out there. But you know what I think I was most excited about was finally starting to hear some of the overall survival data, right? We know these CAR Ts work, but is it finally time for us to understand in that early relapse setting, just how well these patients are doing?
So let's kind of see what we're seeing with bispecifics today. There was also, I think, real world data emerging on bispecifics. And so what has your experience been? Isis, how are you using bispecifics these days in your practice?
I'm using it as often as I can. So for my patients. So I mean, that is what's happening, right? So we talked about some of the difficulties with CAR T cells, and even though they're available now earlier, the majority of the patients are still relapse refractory who come to attention these days for CAR T. So you are sort of kind of leveraging those two trial options. But if the patient is not eligible for a CAR T, the next go-to for me is a bispecific. There's no equal to these therapies out there of any of the options that we have for this patient population.
So as far as the bispecifics go, is there a particular sequence in which you are using these in your practice today?
Absolutely. I mean, I'll be very honest with you. I think most of our patients now, after the recent approval of the CAR T cell, it made it easier for us to kind of like sequencing that CAR T comes first, as second or third line of therapy. There have been a lot of debate about, do you move on directly to talquetamab, which target GPRC5D, or any BCMA drugs? And it's more about a strategic way that we usually choose a BCMA bispecific, teclistamab or olanzapine, and the reason for that is more likely the side effects of talquetamab. And we have been lucky to see actually that still patients like who receive the drugs after sequencing after the CAR T cell, they have response. Maybe it's not as good as in patient with BCMA naive, but we have seen good results in that term. And if they progress on that, we sequencing to receive talquetamab in these patients.
Caitlin, how are you using these in your practice today?
A couple different ways. I kind of love the bispecific just the same because it gives me that option for the patient, particularly who needs something right now, right? The reality of CAR T cells is that it is a process. And there are some patients which cannot wait for that kind of selection and insurance authorization and workup and then manufacturing. And the biology of the disease sometimes chooses the appropriate treatment modality for us. So I really like the go-to bispecific when I need something off the shelf that I can use right now. But I like bispecifics because, if I dare say, they can be a bit promiscuous, right? You can kind of use it in various points of the disease process, in a sense that I've used it also as bridging. Sometimes talquetamab bridging while waiting for CAR T is also an option. Using bispecifics after CAR T relapse, sequencing with different targets. So I think there's a lot of opportunity out there.
Sure. Anything to add to that, Christina?
Actually, the same. I've been using a lot of bispecifics, but if I can, the best sequence, of course, I prefer, to go to CAR T cell first, followed by bispecific. But like Kathleen, I actually used talquetamab as a bridging therapy after collecting the lymphocytes while waiting for the manufacture of the CAR T cell. I used talquetamab for a few cycles in preparation for CAR T cell. Still difficult, to manage in toxicity, but I think the data, the efficacy of these drugs is like outstanding, right? So we are using it more and more and more, but trying to sequence if possible after CAR T cell.
So as regards sequencing after CAR T, so Gurbaksh, where would you use talquetamab after CAR T, and where would you use teclistamab if you would give another BCMA after a CAR T?
So I think the short answer is we don't really know. We sort of are all using our judgments based on the patient profile that's in front of us. It makes a lot of sense to switch the target, right? If you have given someone BCMA, you may want to go to a GPRC5D just because we have not really fully investigated why the relapse is happening. Why is the patient not responding to a BCMA targeted agent anymore? Is it because, antigen escape or other things? So I think switching the target makes sense. So I would go to talquetamab, but in all honesty, that data is not out there yet. We don't know how to sequence these agents. And I think all of us are doing this and are learning in real time, because the landscape in myeloma changes every 3 months. in terms of, hey, CAR T just got approved. All the agents, which were previously Dara, Kyprolis, Dex, we used to give before CAR T. But now what is their space and where do they fall in post? If you end up getting CAR T in first line, in second line after first relapse, we don't know. We're using the data that we have and the best judgments and the clinical experience that we have to sort of learn how to sequence them. But I think that is to be studied in the real world.
So Caitlin, do you have a specific cutoff? Like if you relapse early after CAR T, you're going to go to, a GPRC5D bispecific. If you relapse late, you're going to go to a BCMA bispecific. What's your algorithm?
I don't know if I have a specific cutoff, like Dr. Kaur says. I don't know if we have data that tells us when we can perhaps use a BCMA targeted CAR T followed by a BCMA targeted bispecific, but I certainly do that. And I usually use that for those patients who have had a very good kind of durable remission after having a BCMA CAR T. What that may be, a year sounds good at a minimum, perhaps, and maybe less than that if we needed to. But I usually would kind of draw a line to say, hopefully they've had a good year. And fortunately, with our cilta-cel product, at least, usually we're getting at least that. So for patients who've had cilta-cel and it's been a durable remission, I think you have the option of either GPR or BCMAs targeting for bispecifics next.
So Abdullah, one of the things that I think in the real world analysis on cilta-cel by Surbi Sidana was that it's not absolute that CAR T is not going to work after bispecific. She was able to show that if you have a greater gap between your CAR T and your bispecific, actually the CAR T had a chance of working if it was separated enough from the end of the BCMA bispecific. What's your take on that data?
No, absolutely. I think I agree with that. And it makes a lot of sense. I mean, if we actually look at the data, the pooled analysis from the magnetism studies, they actually studied the erlantinib effect after CAR T cell. It was higher than the BCMA ADC. Actually, and the reason for that, because the BCMA ADC, the patients are getting it continuously, while the CAR T, you give the treatment, you respond, you're not receiving any treatment until like 1 year or 2 years. And the response rate was higher. The BFS was higher in that subgroup analysis. Same thing applied for talquetamab and other drugs. So yeah, I mean, I think it's also same apply for cilta-cel. It makes a lot of sense. If there is a time like, until the, there's a gap, I think there will still be an effect. We also have studied that as well. And we were seeing that, the CAR T cell post BCMA is actually more effective than the TCE after BCMA. So there is actually really good data to show the efficacy of the cilta-cel after BCMA. I think the strategy makes a lot of sense, is just wait, but what time? Are we going to talk about 3 months like the past we talked about daratumumab, 3 to 6 months you have to be off of that to restart the daratumumab or not? I think that's going to be a big question to challenge about that. When is it right to give a CAR T cell post BCMA to see the best efficacy and the longer duration of response?
Would you mind if I just add something really quick?
Yeah, please do.
So I completely agree with what everybody said, but the truth is we don't know. One of the things I think that will change is right now, remember, everyone who is relapsing on an ADC or a bispecific is refractory versus the CAR T patient that has a 2-3 year disease-free interval. That patient is not necessarily refractory. So I think we have to kind of keep that in mind, because I do think how you progress makes a difference. So hopefully, as we start using bispecifics in limited duration, let's say early on, and then the patient is off, they're not relapsing on that patient will probably behave very differently and probably still be very sensitive to a CAR T later on. At least that's my opinion in that sense, as we're seeing some of the mechanisms of resistance coming out of some labs. So anyway, I think a lot more for us to learn on how to.
You bring up an important point. He says the duration of bispecifics. Obviously, nearly all of them currently are studied till progression. So have you stuck to the label in terms of how you administer your bispecifics? Are you kind of improvising and shortening the duration, reducing the frequency? What are you doing?
It kind of depends. So in my relapse refractory patient, I am kind of sticking to the label from a standpoint of maintaining them on. Probably not as frequent as the label asks me to do so, but I am keeping them on. There are definitely patients where, because of toxicities, because of infections, we're definitely stopping, and we do see sort of prolonged remissions in some of those patients. But right now, I am, in my relapse refractory patients, I am keeping them on treatment unless I have to stop for one reason or another.
So, Caitlin, a lot of people are saying you use the DARA schedule. You use it weekly for 2 months, every other week for up to 6 months, and then go monthly. Obviously, that's not what the packet insert says, which is give it weekly for the first 6 months and then go to every 2 weeks. So, what has your practice been?
You know, it was funny when the alnuctamab data originally came out, that was mirroring the DARA schedule so beautifully. We were all like, yes, this is exactly the way we should be doing this. And so I think many of us started kind of putting that into our practice a little bit, because I think while the package insert says just keep hammering every single week, or if it's TAL, you could do weekly or every 2 weeks. I think from a practical perspective, both quality of life, side effect profiles, that's not always going to happen or be the case. So I do think it's important that we follow the label to get to that deep response as long as they're tolerating it. And then think about how we can, if we need to, kind of lessen the interval between the doses. So you're giving it less frequent, for example. Some patients need dose reductions depending on the toxicity profile. So I want to get to that deep response, and then I'm going to back off a little bit so that these patients continue on the therapy for the long run. And that is a little different for TAL versus TEC or ELRA, I think, because sometimes the TAL side effect profile is harder to manage than sometimes the TEC and ELRA infectious side effect profile, which I think we're better at that. So I think it's a little drug specific.
Yeah, we'll obviously come to the toxicity management in a later section, but Christina, what's your practice? Are you deviating from the packet insert in any way?
You know, a little bit like everybody else. I think, unfortunately, it's still approved in these heavily pretreated patients. So it is a little bit concerning, you know, to stop therapy in this population of patients. And also, while we see the responses very quickly within the first cycle and a half, it takes a long time to achieve the deepest response, sometimes several months. And so, you know, if a patient is tolerating the treatment, I push it. If it's not, particularly with the talc, unfortunately, it's a little bit more difficult to sustain a therapy. You really need to do a dose reduction, increase the interval between, you know, administrations. So I try to stay, but like I say, in the real world, is not possible. And you know, I go based on patients managing toxicity, absolutely, like everybody else. Yeah.
So Abdullah, obviously, you know, though a lot of community doctors are not yet doing the ramp up, they are trying to take over the management during the maintenance phase. So what are you telling them? Are you telling them to stick to the packet insert? Are you telling them anything different?
Well, I mean, we do it different here in Kansas. I think we had, unfortunately, several cases like, that had increased mortality because of the infection. And looking at some of the data about, dose frequency adjustment after like the patient achieved complete remission to every other week, we also saw the median duration of response, which was very impressive, and patients who achieved the complete remission. I think the big question here is that now after you achieve that in patients who are standard risk, is it really worth it? Like, what exactly is the bispecific going to do in order to keep the patient in remission other than increase the risk of toxicity? So I try actually to kind of like, for those patients who are high risk, I really actually move on to keep them every other week or maybe once a month. And those who are standard risk, I really actually stop the drug after I achieve a complete remission after 4 months. Maybe people will disagree about that. There's no really strong data, but the risk of the infection that I've seen fungal infection, PCP pneumonia, things I've never seen before that happen in patients who got transplant. I've seen it in using the drugs like teclistamab or relantinib. So I just don't want to lose my patients from an infection, especially if I can keep them in remission as long as possible. For my community oncologist colleagues, I mean, I think they feel comfortable when they do that. In addition to, I try to kind of give them advice about to monitor things like the IgG level, the CBC, and make sure that they have a low threshold to provide supportive care treatment like a growth factor shot and IVIG for these patients.
So obviously you're using more of a risk adapted strategy. So Gurbaksh, so there is data that, by giving longer intervals, you may be reducing T cell exhaustion. Some people are taking that as a reason to do it prospectively. What's your take on this?
So I think early on, when the bispecifics were approved, the patients who were receiving teclistamab right away were patients who were progressing after CAR T. So their disease biology was very different, and I don't think I even needed to deviate from the schedule because they actually ended up not having as durable responses as the patients that I'm taking care of now. So my approach sort of changes based on the patient who's in front of me, what their profile is, as others have said. I am starting to deviate. The patient sort of helps me decide. The patient logistics also play a role. How far they live from the center? Do they have a local oncologist who can actually administer the medication? So I think that burden ends up impacting it. But my general approach is that I try to do a risk adapted approach. It's based on the depth of response. If I have not seen a deep response, I'm not going to back off the drug just yet. But I'm very religious about the supportive care. IVIG, they are getting PCP prophylaxis. We have a robust acute care. So the moment patients have a complaint, they get seen. So I think, bispecific patients are high maintenance patients, just like CAR T patients, and they need that extra layer of support. So I do a risk adapted approach. I back off, but only if I'm happy with the response that I want to see. Of course, if there is a really serious infection, then that sort of helps guide me my decision. As much as I want to keep on pressing on the gas pedal, I might need to put on the brake temporarily until we get the patient in a better condition. So I think it's very individual.
What do you want the community physician to know about what we know and what we don't know about, management of these late relapses? So Christina, you're on first.
It's important to establish a partnership with, the academia where we can deliver this therapy, particularly the CAR T cells, so we can help guide the community physicians how to sequence this drug. To me, it's very important. We don't want to, we talk about the efficacy of CAR T cell after bispecific, and we collect the T cells. So we want to sequence CAR T cell earlier, bispecific later, which one. So establish a partnership, and then a collaboration also on, now we have a lot of experience, like I'm having my own experience. I've treated a lot of patients with bispecific over the last couple of years. And so the capability of also helping with managing, like we were talking about, managing toxicities and other side effects. So it's not just during the first cycle, but how we manage these patients ongoing. And then, again, can we increase the intervals? Can we guide on how long the durability of therapy, the duration of therapy, etc. So I think to me, very important establishing an even closer partnership with our community physicians.
So Abdullah, anything to add there?
Yeah, of course, I echo what Dr. Christina said, and I think this is really actually interested to always to make sure that we are aware about the bispecific have a really big impact, and we know that there is other types of bispecific is going to hopefully come in the future, and we have to make sure that our community oncologists are aware and well educated about how to use that, in the maintenance, and hopefully in the future the step up dose, not only rely on us for that, and I think this type of collaboration have to be translated as well, workshop and symposiums, to kind of make sure that they're up to date with management of the toxicity, because I think that's the most important thing that matters for them, the toxicity and what kind of things they can do to prevent any main adverse events.
Gurbuxh, anything to add?
No, I think most of it has been well highlighted by my colleagues. These therapies are remarkable. They work really well, but there is maintenance that's required, and there has to be an ongoing collaboration between the community oncologist and the academician to keep patients on these therapies and ultimately keep the patient in mind. And a lot of patients get their care with community oncology. So we have to make sure that we have provided our community oncology colleagues with the tools and the experience to help manage them.
So Caitlin, a West Coast perspective?
Yes, I mean, I think my takeaway always is, myeloma therapy is not a one-size-fits-all type of treatment. And I think what we are learning now from kind of real-world data is that the kind of historic culture of myeloma therapies that has been designed to be kind of transplant eligible and transplant ineligible, I think is mistakenly kind of created two groups of patients, where real world data tells us we can be more aggressive in all of our myeloma patients. So really kind of look at all of our patients through a good lens to say, perhaps they are eligible for these kind of novel therapies because we are so good at our supportive care, getting them through bispecifics or CAR T.
And he says the last word, you actually may have a unique perspective because you are at a larger center, but still have a community feel to your practice.
Yeah, no, so I echo everything that's been said. And the one thing I will say, though, is if you notice, we have not mentioned the word cytokine release syndrome and ICANS once in this discussion. And that's what most community doctors fear. So just that happens in the step-up dosing. But after that, it's really the infection management that becomes more important, the cytopenias. And so I think that's my take home, is that you really need to kind of start thinking about these therapies, just like you do with any of your other myeloma therapies, right? With the quadruplets, the anti-CD38s, patients get in trouble with infections. Those are the same kind of things you're going to be looking for in this. And that's what's, as Dr. Abdullah said, that's what can get you in trouble, is a patient gets an infection and succumbs to it. And that's the worst thing to do so when you're in complete response. So again, that maintaining that close relationship with your academic center or your specialist is vital.
Oh, thank you. We will delve deeper into the infection and other risks in the next segment. So obviously there's a lot to discuss about these therapies, and let's move on and get down to the practical aspects of care with these agents in the next segment. Thank you.